So I would like to give you a brief introduction of who we are. So we are the Hasso-Plattner-Institute at Potsdam, so a part of the University of Potsdam, just in the outskirts of Berlin, basically. We founded this digital health center very recently in 2017. Basically, my group has moved there in 2018, and this is sort of the vision that we're working on, sort of at the digital health center. And I think you can all connect to this. Sort of, if you think about how health or sick care works today, you wait for the patient, client, whatever you want to call it, basically, to have a symptom, go to a doctor. The doctor, especially for people like me who have been moving around a lot, basically the doctor for sure sees you basically the first time, knows nothing about you, and just pulls up something out of the head. Typically it goes nowhere, and then you basically go back to going to the next doctor until someone basically randomly sort of looks at the right thing, right? And then you go into treatment. Such treatment is often invasive and often too late. Today we heard a lot about talk about how we sort of, like everybody has this sort of same vision how things would go in the future. That we would move towards basically continuous monitoring everybody based on their own genetic risk for diseases, using sensors and non-invasive screening technologies, typically based on imaging or sequencing. Like if you find something early in this data for a healthy individual, you would either decide sort of a change of monitoring, or and leaving the person still in this healthy state, or involve the doctor. Now, if in sort of a digital healthcare system, the doctor already now has data in its hand and can immediately move to sort of treatment. And sort of in the ideal case, this treatment is minimally invasive, and maybe we haven't even experienced the symptom in the first place because we are looking at healthy individuals. Now, what do we need in order to get there? That's sort of the important part, and sort of we sort of modeled the digital health center in Potsdam around this. So we have now sort of 3 chairs there. One Erwin Böttinger is doing precision medicine. He's working on personalised medicine, electronic health records. So he's a medical doctor, but running a dry lab there. Then there's the sensors. We have Professor Bert Arnrich, who so he likes to talk about how to measure sort of the 99% of the time when the person is not in the doctor's office, right? And myself, I'm doing machine learning. I'm interested mostly in sort of actually in applications in genomics and medical imaging. And this slide's actually not completely accurate. We now have a 4th professor who's doing human-centered design. So I think the design component is also really important in this whole thing, because we're dealing with the patients, we're dealing with healthcare professionals. So there are all these different parties involved, and we basically need to design approaches that are useful in the end and practical. That's Jonathan Edelman, Professor Jonathan Edelman, who joined us from the Stanford D-School. So the Hasso-Plattner-Institute is a computer science institute, and yes, we started a master program in digital health, but we want to sort of go all the way into the clinic. So that's why in 2019 we're starting a 2nd digital health center at Mount Sinai in New York City. So basically we'll move into the Mount Sinai School of Medicine, and we're currently sort of thinking about who are the appropriate people to recruit there. Now, I want to move over a little bit to my own research interests, which mostly around sort of measuring things. So basically today we have these technologies to very broadly sort of measure health-related information using sequencing, imaging, and so on, but often not in people who have a disease, but also in people who are healthy. And we're doing that already in very large populations. If you think about the UK Biobank, we're basically in the UK putting together a data set with 100,000 whole body MRIs. Yeah? Like, why are you doing this? There's no hypothesis. Basically provides you a resource that later you can sort of go back and sort of, once you identified some cases of diseases, and go back and say, okay, what actually happened there? But it's not hypothesis-driven research. It's more about sort of actually developing sort of these models to allow early detection. Basically, you want to see the person before they had the disease. You want to observe the early signs of disease, and then so basically watch progression. And this is, the problem with this is forget that a radiologist will go through these 100,000 whole body MRIs. Yeah, it's impossible. Right now, there are not even the computational approaches to do so. Basically, the biobank is more or less just storing that data, right? And basically providing that as a resource, and the research community can think about, like, what do we do now? My previous employer was Human Longevity Inc. It was Craig Venter's startup. It still exists, but Craig Venter is not there anymore. Where we also worked on sort of these approaches, where we thought about how we can use technology just to broadly phenotype people. So we basically took these 3D facial scans and voice samples and whole genomes of people, volunteers that came in from UCSD originally, and then you phenotype them. And I'm a machine learning person, so I'm thinking about how can we extract phenotypes from data. For example, we want to get the eye color, which is not a health-related phenotype, but it's just a very simple example. We basically, from an image, then we just detect the iris using a deep learning model, and then record the pixel values. And turns out we also have the genomes, and the genetics of eye color is actually really well understood, and we can, from the genome, basically build a model that relates these RGB values to the genome and predict from the genome the eye color better than if you ask the person what the eye color is. Now, not all phenotypes are that simple as the eye color. If you think about sort of the face as a quantitative trait, then it's like, okay, how do we do statistics? It's not something, load 1 million faces or 1,000 faces in this case into Excel and compute a correlation coefficient with something. You need some extra work, but you need to build some pipelines to sort of get a sort of high-dimensional quantitative representation of a face, and then you can do statistics on it. For example, you can try to reconstruct faces from the genome. I'm not saying that this works well, but it's something that one can do. And once one has the model and sort of has set up the pipeline to actually collect such data, you have a model that will improve as you collect more data. And as an example of sort of, like actually collecting data that originally has no health-related context, you actually can think about actually using them to study health, or sort of the difference, variation in health and disease, and aging. Is, I think, is a really interesting phenotype, sort of, that is not a disease but is very related to disease, right? Of course, the chronological age is a really boring thing. You can just compute it from your birth date, but so if you look at our faces, we see a lot of variation in age, and that is something that we can model in order to get something closer to what is more health relevant, something like a biological age, where you can actually sort of, yes, from those faces you can predict age, from voice you can predict the age, but also from the genomes you can get an estimate of the age of the person. The genome is not just a static thing. Turns out that sort of we accumulate mutations as we age, and those we can estimate by looking at those sort of large data sets. So we can measure something, estimate sort of the telomere length, which is sort of the end of the tips of the chromosomes that get shortened as we age. It turns out if you're female, at some point a lot of your cells will lose one X chromosome because you need one only to survive. If you're male, a lot of your cells will lose your Y chromosome because you need the X chromosome only. However, sort of this chromosome loss has also been associated to a lot of diseases, and including a lot of cancers, but I think also some neurodegenerative diseases. And from our genomes we can then also sort of, if we accumulate these models, we can predict also the age. And if you think about it, using it in a health context, if we want to study this further, what is really interesting is sort of this difference between the chronological age and these sort of estimates, because that sort of gets closer. I mean, the question is, what is sort of a measurement error, modeling error, and what is sort of signal from basically one person sort of aging faster than someone else. Going back to those large cohorts, we also have a similar cohort in Germany, which is the NACO, and like we're basically modeling, getting those also whole body MRIs there, and I'm interested sort of in sort of scaling up the sort of quantification of these images, such that we in the end can compute those correlation coefficients with something else and find sort of new things find out new things about health. And again, we need sort of machine learning to sort of quantify, for example, the ejection fraction of the heart by estimating ventricle sizes. And similar things we are doing with brain, ventricles, and so on. If you think about digital health, we're talking a lot about sort of Europe. We are in Europe, so we're very self-centered. But I got involved in a really interesting study in sort of South America. So this is in KwaZulu-Natal, close to Durban. It's an area that has an extremely high health burden in HIV, more than 50% HIV positive there. And also among people who are HIV positive, over 50% had an incidence, at least one incidence of TB in their life. And sort of in the Africa Health Research Institute, we're doing sort of this community-based study where they have these sort of mobile clinics on trucks, go into villages. These are really rural areas, and if you think about sort of digital technologies, they have a huge impact. It could have a huge impact there. So these are areas where there's no easy access to healthcare professionals, and sort of basically we're working on these mobile technologies also there. But basically, on these trucks, they have an X-ray, and people come in, they get a biosample, they get sort of all these questionnaires. And right now we are sort of working on diagnosing TB and quantifying TB from those X-rays there. And with this, I think I would already like to conclude and sort of thank my co-workers and students and collaborators. Thanks.